or whoever. There we go. That's what we needed to hear. Um, so, um, so if you haven't attended one of our TeleEchos, I'm Doug Patton. Rhea Markowitz normally leads these sessions, but she's taking some time out with her family. And Brenda and I are going to run the show today as best we can in Rhea's absence. I serve as the campus dean for the Southwest campus of the Medical College of Georgia. We're located in Albany, Georgia, about 200 miles away from Augusta. But we serve many of the communities or communities that are very much like many of the communities that you all serve in terms of rural Georgia with poor access to dermatological services. Therefore, it falls on the primary care providers to fill in the gap and to be as well trained and as competent and comfortable taking care of these things as you can be. So that's part of why we're here today. If you could put your screen on, if you could turn your cameras on, especially while we're going through this first bit, so we can kind of see everybody. And also to make sure that you see what's going on over in the chat. And so you're putting your name and your organization, as well as your email address in the chat so we can all kind of keep up with who's there. There is the TeleDerm website, which is included, and I think we can put that in the chat if we don't mind, to make sure that that's how people are registering, because it makes it a lot easier to keep up with who's registered, who's attending, and also makes it easier for you on the back end when you're applying for continuing education credit. We have primary care providers from across the state of Georgia and from other places as well, including rural healthcare centers that have been involved with us in our previous TeleDerm project. But we've got folks from East Georgia Healthcare Center who are now part of this second phase of this program. We've got residents and faculty from Family and Community Medicine Residency Program at MCG. We have folks from the Department of Dermatology, including the chair, Dr. Loretta Davis. We have Dr. Kendall Buchanan and Dr. Harold Rabinovitz, all faithful participants and leaders of this. We have MCG medical students, some who are interested in primary care specialties, some who are interested in dermatology, and all sorts of other flavors. We have the Cancer Center TeleDerm team, including Brenda Santiano and Kenza Mamouni. Grateful for their faithful participation in this. It keeps the wheels turning. And then we've got folks from all around the state of Georgia, out of state, and we have occasionally had folks from around the world participating in these. It's one of the beautiful things about the ECHO platform. If you're attending this TeleDerm program and this is your first ECHO program, we welcome you especially and hope that this will lead to something that you find of value. Again, name, email address, and your affiliation in the chat. If you don't mind, if you haven't gotten that done yet, that's just another little reminder. And now we'll review the agenda for today. Today's didactic is again going to be presented by Dr. Vinnie Sieberling from the Department of Dermatology at Tufts University School of Medicine. She's also the director of teledermatology for the national nonprofit Rural Access to Dermatology Society. She firmly believes that all patients deserve high-quality dermatologic care, regardless of where they're located. And so we're lucky to have her with us again today for her second presentation of 3 TeleECHO presentations in sequence. Just as a quick reminder and a little bit of a side departure, all of these presentations are archived and available, and we'll make sure that you know how to get that. Again, that's part of being registered through the ECHO platform. You can access the previously recorded sessions. Few more announcements. The TeleECHO TeleDerm sessions and Zoom reminders. And again, we need to go to slide 9. There we go. Is that the motto is moving knowledge instead of people, and that's what ECHO stands for. And we can move to the next slide now, please. And so this is the general purpose. It's a distance learning platform, but it's intentionally bi-directional. So we hope to hear from each of you who are participating along the way. We'll even talk about the opportunity for you to become a presenter of your own clinical experiences at some point in the future, should you choose to help us with that. This is intentionally designed to dissolve the dermatologic health disparities faced by people living in rural areas of the state of Georgia. Keep yourself muted during the presentation. You can ask questions by typing them into the chat or raising your electronic hand. If you go to the reactions button on the bottom of your screen, you click on that and you'll see the raise your hand thing. We'll be watching for that during the presentation, and we'll try and be strategic about when we stop to answer questions, but we certainly will have a question and answer time after the presentations. So with that in mind, let's see, go to the next slide, please. We'll make sure I don't miss anything. Those are the general Zoom reminders. I did miss the one about the PHI. Just remember, this is not a consultation. This is an educational thing. So please do not share PHI during the presentation, as it would not be appropriate for this venue. So now it's my pleasure. It's my pleasure and privilege to introduce Dr. Vinnie Sieverling, our featured speaker today, who's going to talk about psoriasis and scaly rashes. She'll have multiple case presentations during her talk. And when we get into discussions, we will ask, if you don't mind, Dr. Sieverling, if you can come off the chair after you've completed your talk, and we'll entertain questions at that time. So with that, Dr. Sieverling, I'm going to turn it over to you.
Thank you so much. Can you see the scaly rash?
We can see the scaly rash, and we can see you.
Oh, all right, fantastic. We're going to get started. So as Dr. Patton said, I'm Vinnie Sieverling. I'm a dermatologist. And last time I talked with you about dermoscopy. So we're going to do a little bit of space review and weave in a bit of dermoscopy today. But our main focus is going to be on psoriasis and scaly rashes. I am going to tap into some of my nerd educational powers, one of which is dermoscopy. But more importantly for this presentation, I want to really get you involved. I want to empower you to not only diagnose psoriasis and other scaly conditions, but also feel equipped to manage some of these conditions in your own clinical practice. So in the second half, we'll flip the classroom over and get you involved in describing what you see and generating a differential diagnosis and a management strategy. Overarchingly, we're going to focus on psoriasis. We'll look at the clinical presentations and also some of the associated comorbidities that occur in our psoriasis patients. And we'll work on differentiating psoriasis from other inflammatory skin diseases like atopic dermatitis. And by the end, I hope you'll have a grasp on not only topical medications, but some of the systemic medications that are sometimes prescribed even by primary care physicians. Last time we talked about the importance of skin type, Fitzpatrick skin type, in the evaluation of skin cancer and skin growths, but this is also imperative when we're evaluating skin rashes. Sometimes in phototype 1 or 2 patients, rashes look very erythematous and pink, and in contrast, in a patient with phototype 5 or 6 skin, the same skin condition might not look pink at all. For many years, this presentation difference has led to diagnostic and outcome disparities in patients with phototype 5 and 6 skin. Oftentimes, patients with phototype 5 and 6 skin, it is underappreciated the extent and severity of their skin condition, leading to an increased likelihood of utilizing the ER or developing skin infections for their inflammatory skin disease. So one of the things I want us to focus on is being able to recognize atopic dermatitis and psoriasis across the full skin type spectrum. Let's start by looking at psoriasis in phototype 1 skin and then contrast that with phototype 5 and 6. This is a 55-year-old man with psoriasis for the last 30 years. He has a very widespread erythematous eruption. And when we look at the areas involved, we have almost confluent involvement on the torso. In addition, we have very large numbers of pink scaly patches and plaques coalescing into large areas of body surface involvement on the torso and involving the umbilicus. When we look closely, we can appreciate the fact that the scale in these patches and plaques is nearly confluent, and there is a predilection for areas on the extensor surface of the skin. When we look at his elbows, we can say these are well demarcated pink scaly plaques with striking differentiation from the unaffected skin. Overwhelmingly, psoriasis has a predilection for the extensor surfaces, which contrasts to atopic dermatitis, which more commonly affects the flexural areas. When we compare phototype 1 and 2 patients with psoriasis to phototype 5 and 6, we see a lot of differences. One of the main differences in phototype 5 and 6, we see very little erythema, and oftentimes the plaques of psoriasis have more of a violaceous color and a more silvery or gray scale like we see in the right. In phototype 5, occasionally you will still see some erythema or pinkness, especially under that plate-like micaceous scale that we see in this patient on the left. The differential diagnosis of psoriasis includes a very broad spectrum of annular rashes. Annular means ring-like, and in this annular category, we can have not only inflammatory skin conditions like discoid lupus or psoriasis or atopic dermatitis, but we can also have skin infections. Sometimes it is difficult to differentiate these with the naked eye alone, but if you take a very close look, for instance, at differentiating psoriasis from tinea, we can often get a lot of clues when we look at the edge and the location of the scale. Here at the top of the screen, we have a patient with plaque type psoriasis who has nearly confluent areas of scaling on the plaques. Whereas in this child with tinea corporis and tinea faciei, we see annular erythematous patches and plaques with an advancing rim of scale and oftentimes with central clearing. Sometimes that diagnosis, that differential is not easy to do with just the naked eye alone. And we can benefit sometimes from looking at these scaly patches with our dermatoscope or by performing a KOH scraping of the skin. Under dermoscopy, we get lots of clues at 10x in vivo magnification. Now, last time we talked about the use of dermoscopy at differentiating benign from malignant skin growths, but it's also helpful when we're looking at scaly rashes. 97% of the time in phototype 1 and 2 patients, we will see lots of dotted vessels and scale and a pink background in patches of psoriasis, which contrasts with this orange-yellow crust that we typically see in patients with atopic dermatitis. Here it is again, all these uniformly spaced dotted vessels, pink background and scale, which corresponds to this plaque of psoriasis. Remember though, if you use a liquid medium like an alcohol swab and you wipe the top of the plaque of psoriasis, you will often wipe away that scale. And that is good if you're trying to look for the diagnostic clue of all of these uniformly spaced dotted vessels. It's always important to recognize that we can get an abundance of clues, not just under dermoscopy, but always look at that clinical appearance first before you use a dermatoscope. So once we've made the diagnosis of psoriasis, we then want to ask ourselves, what type of psoriasis does this patient have? Overwhelmingly, psoriasis is one of the most common inflammatory skin diseases we will see in our clinical practice, and it can affect up to 4% of the population. The most common type of psoriasis is plaque type psoriasis, which is what we see here. However, there are other types of psoriasis. One type that we see sometimes corresponding with a prior group A strep infection is called guttate psoriasis. Guttate psoriasis is where we have a raindrop distribution of small papules and plaques with that silvery scale, oftentimes with a large body surface distribution on the torso. Up to 80% of these patients will have had a recent group A strep, either pharyngitis or even perianal strep infection. And the good news is that most of these resolve with treatment with a penicillin-based antibiotic. Other manifestations of psoriasis include scalp psoriasis and palmar plantar disease. Overwhelmingly, scalp psoriasis does not cause what is called a scarring alopecia. So hair loss in the setting of psoriasis is usually secondary to pruritus or itching. For instance, in this patient, there was an abundance of scale causing this patient to scratch and cause some traumatic breakage and diminished scalp density. In this case, this patient also likely has an overlap of seborrheic dermatitis and psoriasis, a term we sometimes call sebopsoriasis. Pustular psoriasis, which is what the patient on the right has, is not a common manifestation of psoriasis, but it's good to keep on your differential diagnosis because typically when we see pustules, we think of a bacterial or a fungal infection. But if a patient's not improving with antifungals or antibiotics, consider that they might have a pustular psoriasis, which is not an infectious process. Instead, these pustules are chock full of neutrophils. These are sterile pustules. And respond nicely to topical steroids if used at the right potency. In addition to skin findings, our psoriasis patients can also have arthritis and nail changes. Of the nail changes, the ones we see most commonly are nail pitting, which we see here, and distal onycholysis, meaning the tip of the nail lifts off at the distal edge. Some of our patients will have profound nail changes where they have 10 nail dystrophy, like the child on the right. This child not only has nail psoriasis, but she also has psoriatic arthritis, manifesting as proximal interphalangeal joint swelling and what's called a sausage digit. When we look at other nail findings, we can see distal onycholysis here and what are called oil spots, these black areas in the nail. Nail psoriasis can be a clue that the patient might be at higher risk of having psoriatic arthritis. So I always pause and make sure I'm asking my patient about joint disease, especially if I see significant body surface area or nail findings in psoriasis patients. The joint findings can be in large joints or really have a profound impact on the hands. This is a patient with widespread psoriasis and joint psoriasis. And we can see here how psoriatic arthritis has a predilection for the distal and proximal interphalangeal joints, not as much involving the MCP, which is more commonly involved in rheumatoid arthritis. The other thing to know is that psoriasis is a systemic inflammatory disease. Going back nearly 20 years ago, Joel Gelfand and his team at Penn found that the psoriasis was an independent risk factor for the development of a myocardial infarction. Since that time, they have found that there is inflammation in many of the joints, but also many of the organs in the body, not just the heart, but also in the liver and in the gut and also in the brain. So when we think about psoriasis, we need to take a systemic approach. For years, psoriasis was called the heartbreak of psoriasis, thought to be causing patients a significant amount of depression and reduced self-confidence because of the cosmetic appearance of it. Well, that can indeed be true, but what's also true is that patients with severe psoriasis have been found to have documented increased vascular inflammation in the brain, which corresponds to higher rates of depression and suicidality. So we want to take psoriasis very seriously and get these patients the medications that they need to reduce the systemic inflammation in their body. So on to treatment. When we look at a patient with psoriasis, we need to take into consideration many things. The first that I think of is what is their body surface area? The next is, do they have systemic involvement of other things like the joints? Now, when we look at this patient with psoriasis, we can see he has a very significant body surface area. But even with patients who have significant body surface area, they often need topicals in addition to systemic agents. When I think of my treatment algorithms for psoriasis, they almost always involve topical steroids, many times also a non-steroidal topical, and then oftentimes, especially if the patient has more than 10% body surface area, I'm going to be considering a systemic agent. Topical steroids are a workhorse of treatment for not just psoriasis, but also atopic dermatitis. One thing that I want to encourage you, especially in the primary care setting, is to get comfortable prescribing topical steroids. We want to make sure that our patients are receiving the sufficient potency and quantity of the medication for their skin disease. When we think about potency, that refers to the quantity of drug necessary to give an effect, or the maximum response which can be achieved from a medication. So a lot of times I think about it like hydrocortisone. We can get large quantities of that over the counter, but even with large quantities of hydrocortisone, you may never get the outcome you need because it's simply not potent enough. I like to keep my prescribing practices pretty simple. So most of the topical steroids I prescribe are on this list. Over-the-counter hydrocortisone is 1% strength, but you can prescribe 2.5%. The workhorse of all topical steroids in my clinical practice is triamcinolone. And triamcinolone is wonderful because you can get a 1 pound jar, 454 grams of it for a very affordable price. Other topical steroids with higher potency are fluocinolone and clobetasol. Now, when we consider topical steroids, we also have to consider how does that medication get to the area of inflammation? And that's where vehicles matter. If we have a patient who has significant scalp psoriasis and they have a lot of hair, we don't want to then prescribe a thick, greasy ointment because it is unlikely for that medication to get to the area of inflammation. And we will want to choose something else like a shampoo or a foam or a liquid based vehicle to allow for delivery of the medication to the base of the scalp. In contrast, if a patient has a very thick plaque of psoriasis on an area like the palms or soles or elbows, then I will often use an ointment-based vehicle because that will increase the likelihood of permeation through the stratum corneum to the area of inflammation. Few more words about topicals before we move on to systemics. One of the things that I'm often asked is, are there steroid-sparing agents for psoriasis and for atopic dermatitis? And there absolutely are. More and more, we are using a medication called roflumilast, which is a phosphodiesterase 4 inhibitor, which is FDA approved for treatment of psoriasis on the scalp. It is fantastic in many ways in that it is a foam, which means that we have the ability to get it onto hair-bearing areas. Another FDA-approved treatment that can be used for thin-skinned areas like the face and genital skin is tapiranoff, which also can be used for atopic dermatitis. Now, many times those medications I just mentioned are difficult to get covered without prior authorizations. However, I'm often able to get tacrolimus covered. Tacrolimus is a non-steroid agent that is more commonly used for atopic dermatitis, but there is certainly efficacy for seborrheic dermatitis and for psoriasis. It comes in two strengths. This is a calcineurin inhibitor, so it is not a mechanism of action like a topical steroid. It comes as a 0.03%, which is often what we use in younger children, and in a stronger potency for adults. What is wonderful about this is it's safe to use on the face. All right, moving on from topicals. Sometimes our patients have systemic involvement, they have psoriatic arthritis, or they're very frustrated with their body surface area, and a systemic agent is more appropriate. I put this slide on here on purpose. It is very complicated. It is very difficult to know where to start. That said, many of my colleagues in primary care and some who are working at federally qualified health centers have chosen to embrace this and to see which ones are going to be most beneficial for their patients. And of these, it's usually the TNF blockers. And the reason for that is there are overlapping indications with other diseases like ulcerative colitis and Crohn's and other inflammatory skin diseases for which some of these medications are helpful. So With that, it's important to consider that there are some red flags. You need to be cautious if you're going to start a TNF blocker, if a patient has any history of a demyelinating disorder, or if they have congestive heart failure, you really might want to choose a different category of drug. And the other thing is, oftentimes these drugs initiations are done in partnership with a dermatologist or in partnership with a rheumatologist to really help guide which one might be the most beneficial for the patient, because it is a very complex decision and we want to make sure that we're selecting the right one for the right patient. All right. Overwhelmingly, though, if we start a biologic medication, there are really beneficial results, not just for the skin. What we're able to see is reduced systemic inflammation, which has corresponded to reduced likelihood of coronary vascular events, as well as reduced issues with coexisting inflammatory bowel disease and reduced rates of depression symptoms. So I encourage you, if you have a patient with a high body surface area or with psoriatic joint disease, consider a biologic or systemic agent. Okay. I have lots of cases from around the rural areas that I've worked in, but I do want to pause because I know last time my didactic portion was too long. So, are there any questions before we really dive into some cases and practice what we just reviewed?
Thank you, Dr. Seiberling. I think you're right on time. I think we're doing great. So let's do see. I don't see anything in the chat. Does anyone have any questions they would like to ask? Either raise your hand electronically or just open your mic and speak up.
How
Oh,
long is the treatment? I think it depends on which treatment you're referring to. But how about we do our first case and then we'll see if we answer that. But so let's start with this. So this is a case from Maine. This is a 17-year-old boy. He moved to the United States from Thailand and he suddenly developed a very widespread rash. He went to see a pediatrician who felt unsure of the diagnosis and referred him to dermatology. It took him 6 months to get in with the dermatologist. They traveled 2 hours to see the dermatologist, and the dermatologist diagnosed him with psoriasis, but didn't feel comfortable managing psoriasis in a child and referred him on to see me. At the time, I was practicing at Maine Medical Center, which was another 4 months. So he suffered with this for 10 months. And the only thing that he had received from that dermatologist was 30 grams of fluocinolone. Now, I need to pause there and say that that's the amount of medication that would cover an adult body one time. And he was using it very sparingly, and clearly he had significant body surface area. All right, so now he's in our office. We need to take a approach, which is first, let's describe the morphology. There's no wrong answer here. If anyone feels comfortable unmuting yourself, throw out what you see. What's your differential? What's your body surface area? Anyone feel comfortable? And you can go ahead and put it in the chat too if you'd rather. All right. Lynn's going straight for the diagnosis. I love it. I know you are a seasoned clinician, so she went straight for psoriasis. Fantastic. Anyone want to do a morphology description? Any residents? Not. Um, let's see who's on.
I love it. You're going to pick on somebody. That's great.
Well, you're not, you're a dean, so I'm not really supposed to do that, but I could pick on Kendall because I think Kendall would be willing to give us a morphologic description. Oh, or Irene did it already. Love it. Okay, so large scaly plaques. And the point here is to get to that morphology. A plaque, by definition, is raised, and that is what we see in psoriasis. So we see large areas of body surface area with confluent plaques, some of which are quite scaly, well demarcated. And in this area, we can see that there is quite significant involvement of the extensor surfaces. It's not exactly sparing the flexors, but there's a predilection for the extensors. All right. And I know you're not mind readers. So when I say other considerations, I mean this child has been in the United States for 10 months and he has not gone to school at all because of this rash. His parents do not speak English and they live about many hours from where we saw him. So sometimes it can feel a little unclear where to start, but in a child like this, we need to initiate treatment as quickly as possible. 1/3 of psoriasis cases begin in childhood, and an accurate diagnosis helps us initiate treatment. He does have psoriasis. He does not have an infectious condition, and he does not have atopic dermatitis. And we're able to make that diagnosis based on the clinical morphology. And now, what does he need? So, we really need to take a systemic approach. We need to get vital signs in our dermatology office, which I know you do in every primary care visit. And we need to start to get some blood work and other things to make sure that we can get him started on a systemic agent. While we're waiting for that blood work, we want to get topicals and we want to get him a lot of topicals to see if we can at least reduce some of the burden of disease that he's experiencing. Overwhelmingly, we want to take a more systemic approach, and that aligns with what the 2020 consensus guidelines from the American Academy of Pediatrics and the AAD issued for psoriatic pediatric patients, which includes checking for dyslipidemia and looking for other comorbidities at a relatively young age. So, in addition to blood work for starting a biologic, we also checked his lipid panel. This aligns with other recommendations from the pediatric psoriasis literature, which say not only do you check for dyslipidemia, but you should also be screening for arthritis, which is less common in pediatric patients, but also pay close attention to their mood and depressive symptoms because this can be very impactful in young children, especially teenagers' lives. So what we found was he had a BMI of 28. We got him in with a social worker and a dietitian. The social worker was going to help enroll him in school, and we were also able to get him a therapist to help cope with some of the significant transitions he had experienced in moving from Thailand and then developing this rash. We got a CBC, lipids, and his CMP and tuberculosis quantiferon testing were all negative. We got him a 1 pound jar of triamcinolone because that is going to give him at least a week, maybe two, of treatment. And he can use that twice a day on areas other than the face. And sometimes we're very cautious in the intertriginous areas and areas with very thin skin, like the axilla or the groin, because we prefer to use either a non-steroid in those areas or a lower potency topical steroid. And then I'm really happy to say that we're able to get him on adalimumab because it was covered by Medicaid main care. And we were able to get him not only started on that within 1 week of coming to see us, but he also attended school only 3 weeks later. So I'm going to pause on that case, yes, before we go on to any others and see if anyone has questions or comments about that patient.
I think that's an incredible story, especially being able to get the kid back in school in 3 weeks from the time. We have a lot of access issues. Language in this kid is one. Distance obviously is another, and finances as well. You knocked out two of the three. You didn't get him to relocate, but at least you got him the care.
Well, in the spirit of teledermatology, this is the type of patient that we want to do an e-consult for so that we can do teletriage and not wait that 6 to 10 months to get a child like this into care. So,
And
okay, I
that's
got
and
you.
that's basic telemedicine, not requiring. I mean, it can be augmented obviously by a dermatoscope, but this is very helpful. So this is exactly the kind of things I hope that we could see and get comfortable with. Thank you.
Absolutely. All right, I've got a couple more. We have an 11-year-old, and this child actually lives in rural New Hampshire. They traveled 2 hours to see me, and this came on in less than a week. He had no upper respiratory tract infections, and he was an otherwise perfectly healthy child. And here we can see he has involvement on his face. And I should have stated, I have signed written consent from the parent and the children for all of the cases that I present for educational purposes. But please don't take screenshots of them. So this is this child's torso. Yeah. And here's the dermoscopy. All right. So what's our morphology in this case? Sylvia says plaque-like psoriasis. Absolutely. And we've got significant chunk involvement. Absolutely. Great. All right. What's our body surface area? Approximately, I should have said the palm of a patient's hand is 1% body surface area. And so what we often do is we go around and we actually count. Now, for the purposes of this, we can't see the whole body, but I think it's important for you to recognize that this is yeah. Oh, no, I would say it's a lot more than 3 to 10. And the reason is when we look back, it's almost confluent in some areas. Yeah, I'd say 40 to 50%. And he even has facial involvement. Okay, so considerations. He lives 2 hours away. His mother sadly was just diagnosed with stage 3 breast cancer, and she was about to have a mastectomy and start chemotherapy. She was not going to be able to bring him for frequent visits, and so we needed to act quickly and start something that was going to get him again back into school. So in his case, he had a normal BMI, normal blood pressure. His blood work was completely normal, including his ASO, which we sometimes check if we're wondering about gut-tape psoriasis triggered by a recent strep infection. So we gave him a 454-gram jar of triamcinolone, and we were able to get him a home photo unit. Home photo units are something that we can occasionally get for patients who live at a great distance from a dermatology office, and this is narrow band UVB. It's different than a SAD unit, those seasonal affective disorder lights. Those are different than narrow band UVB. It's a different wavelength of light therapy. And for him, this was the really only reasonable option because his mother did not want him going on a systemic agent like a TNF blocker because she was about to have chemotherapy and she was going to be more susceptible to infections. And we know that some, especially ones that are approved on children, are a slightly increased risk for developing upper respiratory tract infections when patients are on these TNF blockers. So we did the light unit and the topicals, and 4 weeks later, he had a very, very significant improvement. It's not perfect, but we made a huge impact, and we were able to do this without any more travel for care. All right, Dr. Patton, that's a fun one, but I have two more really fun ones. But I want to know if anyone has questions. I want to go back to the person's question who said, how long? So there's a rule of thumb for topical steroids, which is twice a day for 2 weeks. You should see significant improvement in that inflammatory skin disease at that treatment interval. If not, you want to pause and revisit your differential diagnosis. Because if you're putting a topical steroid on something that's pink and scaly for more than 2 weeks and you're not getting any improvement, or if it's worsening, you're going to want to revisit the potential of a fungal infection or a different diagnosis.
I think that's a huge pro tip right there to help us begin to understand how long you can try something empirically to see if it's going to work. I'm struck a little bit because I would anticipate, especially in pediatric populations, some scratching like this. Like, are they?
Oh, we'll get to that.
Okay, all right. Ahead.
Psoriasis isn't as itchy as atopic dermatitis. Perfect timing.
All
So
right.
atopic dermatitis, you can see the kid on the right, he's scratching. So atopic dermatitis contrasts with psoriasis in the sense that it is more likely to occur in younger children. It has a predilection for the flexural areas. In young children under age 1, we see a prominent involvement of the cheeks oftentimes, and these children are terribly itchy. They aren't sleeping, and no one at home is sleeping, and they scratch so much that they often develop, sadly, secondary skin infections. Those secondary skin infections can be very serious, and I'm sure that Dr. Davis and her team have to care for some of these patients inpatient because these children are miserable. Their skin barrier is broken down and they develop secondary, oftentimes staph infections, which is what we see here, and they are very irritable because of the pain and itching. So, oftentimes, Dr. Patton, this is what we see. We see the scratch sign. These kids are terribly uncomfortable. And when you see this, you need to ask yourself, how severe is it? This child is actually a phototype 5 child skin. So his normal skin type is actually very brown in color, and he's nearly erythrodermic. And so that means he is red head to toe, and he is really in need of what we call soak and smear. He needs coated in a thick coat of triamcinolone to shut this all down, and antibiotics to treat any coexisting infection. Couple red flags to think of for atopic dermatitis is not only kind of in uncontrollable itch, but also if they have fevers. Fever would obviously be a sign of infection. Now, in this child has what's called eczema herpeticum. Honey-colored crust can occur in two situations in atopic dermatitis patients. That's either a secondary staph infection that's impetiginized or in HSV. HSV can also cause honey-colored crust. And so he has lymphadenopathy, a fever, lethargy, and grouped vesicles on this pink-red base. And there it is, telling us it's a vesicle, not a pustule, because when we unroof it, there's clear color inside. Okay, so that's eczema herpeticum, and the take-home message here is that atopic dermatitis is itchy, and that makes it predisposed to increased likelihood of skin infections. And we tend to see this in children under age 10, whereas psoriasis in younger patients is almost always onset in the teenage years. But these patients also need a systemic approach, and in these cases, we often use antibiotics because most atopic dermatitis patients still are infected with MSSA, not MRSA, which is fortunate. And we often need to use additional agents, sometimes light therapy, and more commonly a medication called dupilumab, which is FDA approved for even very young children with severe atopic dermatitis. Um, did did that answer your question, Dr. Patton, as to why the psoriasis patients are not as itchy?
It points out a clear contrast when we're trying to figure out what's going on, and that's super helpful. Um, did, okay, got another one?
Oh, I got two more.
Okay.
I came prepared. I get to show my favorite one. So this is my son after he's picking his green beans in central Pennsylvania. So I have two cases now from central Pennsylvania where I've practiced for the last 2 years. And this is a sad case. She is a 36-year-old woman who kept going to the emergency department because she could not get this rash under control. She went to see her primary care doctor. She was given some hydrocortisone and referred to dermatology, but it worsened significantly while she was waiting for the appointment. And the most severe part was that her feet were hurt. They were painful, they were fissuring, they were cracking, and they were scaly. So, this is her initial presentation to the ER. And this is what her back looks like. She was given prednisone by the emergency department and it briefly got better, but then it got much worse and she went back to the emergency department. We can see here she has a lot of body surface involvement. Okay, so in the interest of time, we're going to skip ahead to when she saw me. So she was able to get an appointment 6 months after her initial visit to the ER. We were able to diagnose her clinically and dermoscopically with psoriasis, violaceous, well-demarcated plaques with confluent scale. And here we see all those little red dotted vessels that we often see in patients with psoriasis. Now, I do want to pause and say, it's not wrong if someone wanted to do a biopsy here because other things on the differential like lupus or the differential here could include many different things. But in this case, we were able to make the diagnosis with our dermatoscope, and she had at least 50% body surface area. So here, the other consideration is that not only does she live far away, she has become unemployed and she had to move home with her parents because she was unable to work as a cashier because she couldn't stand on her feet all day because of how severe the rash was. And she's also trying to conceive. She had just gotten married. And so, what do we do? Well, we've got to start by addressing her feet. This is when she came to see me. When we think about the medications for the feet, was tinea pedis, here we go. Was tinea pedis on my differential? Oh, that's a great question. When I gave this talk recently, someone else also asked me that. So yes, and if you saw tinea, if she didn't have her whole body involved, or she had an she had HIV or some other immunosuppressed state, then I would be more worried about a systemic infection or fungal process. But the nail dystrophy she has is more consistent with psoriasis, and her triginous areas, like the areas between her toes, are really not macerated. So, and her nails are involved as well. Yes, she has absolutely. But feel free, Dr. Davis or Dr. Rabinovitz or Dr. Buchanan, if you have other advice on how you would have differentiated a fungal infection.
Not so much that, but I am curious, Dr. Sheldon here. On the soles of the feet, it's sort of honey colored,
Hmm.
crusted lesions. Where on I guess the dorsum, it's more purple or
Why does
black.
Berardi avoid airwood?
Oh yeah. So
I don't know.
this is more violaceous. And that's why that's psoriasis's manifestation in a phototype 5 or 6 patient. Now, I will say if this had not cleared up with the clobetasol I gave her, I would absolutely revisit the possibility of a secondary infection. But secondary infections are far less likely in
Why
psoriasis
does
patients. I think maybe you can mute yourself. And yeah, or I can mute her. There we go. Okay. So in psoriasis patients, we're much less likely to see secondary infections than we are in atopic dermatitis. But if this was not getting better, Dr. Sheldon, I would definitely consider adding an antibiotic or scraping for KOH for a possible fungal infection. So here's what we did. We got her clobetasol ointment because we wanted something that would be able to penetrate that thick scale. We got her a pound jar of triamcinolone. You're probably seeing a theme here. I love getting people pound jars of triamcinolone. She had no arthritis. She had normal vital signs. She did not have dyslipidemia, and she had none of the red flags we worry about for potentially starting a systemic agent. Now, one of her biggest things was she wanted to start a family and she wanted to get pregnant, and she had been unable to get pregnant for several years. So we selected a systemic agent, adalimumab, which has been shown to have nice safety in patients who are pregnant or wanting to become pregnant. And here it is, 3 months after she started that. And I am thrilled to tell you that she was also pregnant at her follow-up visit. It was one of my most happy patient encounters in my career. And while she's wearing a gown here, she came into my office with a bikini on, which I've never had a patient do before. And she wanted to show me how much better she was. And what I want to show you is her feet still have what's called post-inflammatory pigment alteration, but that does not mean she has active psoriatic disease. So this was one of the best cases in my whole career. And I think that we can get to this, especially collaborating with primary care to help get these patients initiated on the medications that they need fast.
Looks like she had some improvement in her nails too, because they look shiny. I know that she's painted them, but they look pretty rough.
That actually, I didn't think about that. Her nails responded beautifully. And nail psoriasis is very hard to treat with topicals alone, but systemics help a lot. Okay, is it okay if I do one last case, Dr. Pat?
Absolutely. We got time for one more. I know you're moving quick. Let's go.
Okay, so this is a neighbor of mine. He's a green bean farmer here in central Pennsylvania, and he has psoriasis, and he was well controlled on adalimumab for years. And then the pandemic hit, and he became scared, as many of our patients did. And he stopped it abruptly due to worry for infection. And he was actually okay for a few years. And then over about 2 years later, some new plaques of psoriasis started to pop up. And his wife had some triamcinolone from years past, and she started to put it on some of the plaques. And some of them were responding, but others weren't. So in the interest of time, we'll skip that part, which is well-demarcated pink plaques with silvery scale. And what his wife asked was, are all of these new plaques and patches on the upper back also his psoriasis? Because she had been putting the triamcinolone on these, but they weren't responding. So this is what they looked like under dermoscopy, the areas on the upper back. So my question for you, and feel free to use the chat, is does this look like this? So on the left is the patient's back, and on the right is psoriasis.
No, it does not look
Yeah,
like it.
I would say no. On the left, I see shiny white structure.
I love it. We've got Dr. Sheldon and Dr. Buchanan in agreement. I agree. They don't look the same, right? And Kendall, did you say you saw, what did you say you saw?
Yeah, I saw shiny, like it looked like some shiny white structures in there.
Absolutely, which makes you think of what?
Basal cell.
Basal cell. Beautiful. All right. So what Dr. Buchanan just saw under polarized light is the presence of what are called shiny white structures. Now, when you look at non-polarized light on the right and you contrast it with polarized light on the left, you can't see shiny white lines in non-polarized light. All right. So here are the shiny white structures. That's these. We have short, fine telangiectasias as well. So these are indeed basal cell carcinomas. So this patient came to me with psoriasis and 2 basal cell carcinomas. And the reason that triamcinolone wasn't working on those patches on his upper back was that they were not psoriasis, they were skin cancer. So what did we do? At that first visit, we assessed his body surface area. We got his vital signs. We got some blood work. He was having joint pain, so we also referred him to rheumatology, and we biopsied the skin cancers. And then when he came back, we saw how was the response to topicals. The rheumatologist said he indeed had psoriatic arthritis, which pushed us to starting a systemic agent, and we knew we needed to treat his skin cancers. And an added element, he had hypertension. And when we think about what medication to start for patients with hypertension and psoriasis, we tend to try to less likely favor the beta blockers because they've been linked to having a harder time to get our psoriasis patients under control. All right, so in the interest of time, we're just going to keep going here because one thing to know is that the TNF blockers are incredibly helpful for psoriasis, but they do carry an increased risk of infection. They carry an increased risk of non-melanoma skin cancer. This is particularly true for patients who have rheumatoid arthritis who've been found to have significantly higher rates of squamous cell carcinoma while they're on TNF blockers. So now we have a patient who has psoriasis. He was previously on adalimumab, which is a TNF blocker. He now has psoriasis still, and he has 2 basal cell skin cancers. So what should we do? Well, we should probably pick a different agent. And we decided to go with an IL-17 blocker. And the reason for that was it does not increase the likelihood of developing another skin cancer, and it will also treat his concomitant joint disease. All right. So the take-home messages here are that our psoriasis patients can get not only psoriasis patches, but also scaly pink patches that are indeed skin cancer. And our dermatoscope helps us differentiate skin cancers from psoriasis, and that we have many options for patients. Even if they were previously on a biologic, we can go back and try that again, or we can look at other choices. And sometimes patients with skin cancer really should be on different agents. I think I've shown you the cases that really came from a very large geographic catchment. One of the things I've learned in putting this talk together is that being in a rural place carries that rural mortality burden, and we want to reduce that for our patients. And the National Psoriasis Foundation has some really helpful tips for managing these patients, because only 10% of rural communities have a dermatologist who prescribes a biologic. So sometimes primary care practitioners start these medications, and that can be life-changing for our patients. If you're interested in learning more about how to do that, bring your questions to the next echo, or take a look at the National Psoriasis Foundation website. I'm also going to be there in person to see some of you in a few weeks. And I'm also going to be coming to East Georgia. And then our next talk, because I squished in topical steroids and psoriasis into this talk, the next talk we're going to talk about skin biopsies, unless there's a opposition to that. But Dr. Pat and Rhea gave the thumbs up to that. So hopefully we can get a thumbs up from the group on that too.
Absolutely. I think putting the tools in people's hands is part of what we're here for. So that sounds great. So we are at time, unless somebody has a question that can be answered like in 20 seconds or less. We're going to need to put a bow on this one and wrap it up. This has been great. I still have a lot of questions, and so we'll save them for some follow-up conversations at another point. We want to be true to our time commitment here. Looking forward to the next session. Let's see. Again, Dr. Seiberling, we want to thank you for that. It was great. It was packed full and some very useful tips. The CME and CNE credit information is included there on that last slide, and it'll also be in the chat. You have to be registered before you can get the CME code. Our next session, as she mentioned, will be December 3rd at 4 o'clock, talking about skin biopsies. And if we do have folks out there, and you guys have been very engaged with Dr. Seiberling in these presentations, and we appreciate that. So hopefully we can get some of you to share with us some of your own cases that might be a useful add-on here. We know you're seeing the challenging cases, so please don't be stingy and share them with us. With that, thanks everyone for attending. For those on the TeleDerm team, if you don't mind sticking around for just a couple of minutes, we'll debrief briefly. But for everyone else, again, we want to thank you for your participation and for your active engagement in the process today.